webcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon, everyone, and welcome to today's webinar, a case-based conversation on fetal and neonatal alloimmune thrombocytopenia. My name is Dr. James, and I am a professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine and a consulting professor of medicine in the Division of Hematology at Duke University. I'm also the founding president of FWGBD. As well, I will be moderating today's webinar. Next slide. Just a word about the foundation. The Foundation for Women and Girls with Blood Disorders, or FWGBD's mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the unique issues and medical consequences for women and girls with blood disorders. Next slide. Since its inception, the foundation has focused on realizing the vision through these objectives. Next slide. We have a renowned, engaged board with deep expertise in treating women and girls with blood disorders. Next slide. Just a word about housekeeping. To ensure the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Dr. Bussel at the end of the webinar. You can submit your questions during or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen. And we will address them during the Q&A session at the end of today's presentation. Next slide. Just a word about our faculty. The didactic portion of our webinar will be presented by Dr. James Bussel, Professor Emeritus at Weill Cornell Medicine. He is renowned for his lifetime of work in both pediatric and adult thrombocytopenia, specifically ITP and fetal and neonatal alloimmune thrombocytopenia. He has published over 400 papers predominantly in these areas. And despite retirement, in quotes, he continues to teach, to chair the Platelet Disorder Support Association Medical Advisory Committee, and to serve on the Research Review Committee of FWGBD. In 2012, along with Dr. Richard Berkowitz, maternal fetal medicine specialist, he shared the King Faisal International Prize for Medicine, the so-called Arab Nobel Prize, for their research in non-invasive management of fetal and neonatal immune thrombocytopenia. We are thrilled to have him share his expertise with us today. The two cases that will serve as a springboard for this discussion will be presented by two of our fellows at Duke University. The second case will be presented by Dr. Ade Canedo, a second-year fellow in maternal fetal medicine at Duke University. She received her MD and PhD in biomedical science at the Morehouse School of Medicine and obtained her OBGYN residency at Case Western Reserve University. During her tenure at Duke, besides mastering the management of very complex pregnancies and spearheading a process to rapidly mobilize key personnel and resources to optimize maternal and fetal outcomes at the time of delivery, she is researching placentally derived exome-bound SFLT and placental growth factor as a predictor of preeclampsia in women with rheumatic disease in pregnancy. She will be presenting the case of a woman with a previously affected neonate who consulted us for preconception counseling. The first case will be presented by Dr. Jeff Fetterspiel, also a second-year fellow in maternal fetal medicine at Duke. He received his MD and PhD in health policy and management at the University of North Carolina and obtained his residency training in OBGYN at Johns Hopkins University. During his tenure at Duke, besides mastering the management of very complex pregnancies and spearheading stepwise management of postpartum hemorrhage, he is developing a personalized risk assessment and prophylactic strategies for thromboembolism after cesarean delivery. He will be presenting the case of a woman with previously affected neonate who is currently pregnant and receiving treatment. both Dr. Ade-Canedo and Dr. Fetterspiel have received a number of awards, grants, and have a number of publications. Next slide. I think we have Dr. Bussel's disclosures. The next slides. The next few slides detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. CMA will be provided to physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CMA CE credits for the webinar after its conclusion. Next slide. Before we begin, we'd like to take a quick poll to see how many people are joining us today along with others. Please take a moment to answer the poll question on your screen. We'll give you just a few seconds there. Okay. Now I'd like to turn the call over to Dr. Fetterspiel for our first case presentation.
Well, thank you so much for the introduction, Dr. James, and thank you all for attending. I'm Jeff Fetterspiel from Duke, and I'm happy to present this first case. The next slide, please. A patient came to us in consult clinic one day. She was a 28-year-old para 1. She was 12 weeks and 3 days. She was a patient of one of our community practices that deliver at one of our community hospitals. And she asked to see MFM because in her last pregnancy, she had a very uncomplicated antenatal course. And then unexpectedly after her vaginal delivery, she reported that her baby went to the NICU, ended up actually being transferred from the community hospital to Duke University Hospital for NICU management. And really her question for me was, this happened in my last pregnancy. Should I deliver at a hospital like Duke in case this happens again? She didn't have a lot of detail about sort of the circumstances of that delivery. Her medical history was notable only for a mild, or her pregnancy history was notable really only for a mild thrombocytopenia in that pregnancy to platelet count of 125, but otherwise quite non-contributory. And when I reviewed her records, what I found was that her delivery was noted to be a spontaneous vaginal delivery at term. apgar scores were 8 and 9. There was concern for intraamniotic infection during her labor course, but really nothing else in her labor course that was notable. The baby was transferred to the NICU at 4 hours of life for respiratory distress, at which point a chest x-ray was read as being concerning for meconium aspiration. Next slide, please. Of note, though, when they actually measured her labs as part of her rule out in the ICU for concern for sepsis, her first platelet count was noted to be 25. Next slide, please. With that finding in mind, the patient was transferred from the community hospital to Duke University Hospital. Empiric antibiotics were started and the sepsis rule out process was ultimately completed with culture negative results. The baby's platelet count was trended. It natored at a platelet count of 7, and at which point pediatric hematology was consulted. They recommended proceeding with platelet transfusion, which resulted in a platelet count which rose from at that point about 25 up to 83. And you can see really that it came down again to about 60, stabilized in the 60 range, and then we started recovering to a normal range without further intervention. The baby was noted to be irritable, and on head ultrasound there initially was concern for possibility of edema. So in this setting, pediatric neurology was consulted. They recommended an MRI, which read as normal, and the baby developed normal neurologic exam status and has ultimately had a very normal neurologic outcome. And really the baby improved and was discharged on hospital day 5 without any apparent sequelae. I just wanted to pause there and let Dr. Bussel chime in if he has any thoughts or questions about the history.
Just a couple of things. From the mom's platelet count was 125, so there could have been confusion that the mom had ITP and the baby's count was related to ITP. I would just say that it was much more likely to be either illness related or gestational thrombocytopenia, And normally, if it was ITP causing the baby's count to be low, unless the mom had had a splenectomy, you'd expect the platelet count to be much less than 100,000. I would also point out that random platelet transfusions are now the recommended initial treatment, even if it's FNAIT. So that means you don't have to know anymore whether it was FNAIT or something else. You can give a platelet transfusion and see what happens. As far as obtaining an MRI, I think increasingly, and I don't know what happened in this case, you can use the feed and swallow technique, swaddle technique, where you let the baby get a little bit hungry right before the MRI, feed them and swaddle them, and they almost always will sleep well, and that way you can get an MRI without doing sedation. And I think that's very important because the degree of radiation to the neonatal brain with a CT is remarkably high. And finally, in this baby, you could have thought, oh, this baby might have been septic and that's why the platelets were low. And it was very important, as we'll see, to think of FNAIT with that low account. And one last point, which is, despite how low the count was, you can see, based on where the count stabilizes, you can imagine that the platelets started going up relatively quickly, even without the effect of the platelet transfusion. And surprisingly, this is common for FNAIT, even when the platelet count is very low. And that's not what we see in a newborn with a mother with ITP, where the count typically isn't as low at birth, falls after birth, and then stays low a little longer. Go ahead, Jeff, sorry.
Those are great points, absolutely. We're going to proceed to the next slide, please. Pediatric hematology, when they signed off on baby's care, did raise the possibility of FNAIT being contributing versus sepsis. But given there was no need for further intervention, it wouldn't change their management, was their thought. They mentioned in their note that it was important for the mother to know that there was a possibility of an effect on subsequent pregnancies. It's not clear whether the maternal patient was actually sort of made aware of this, and FNAIT testing was not performed at this time. Next slide, please. When we saw the patient, in reviewing her history, we did think it was possible, possible, even probable that this was a non-recurrent event such as intraamniotic infection, particularly given how robust the responsibility transfusion was. But we also felt that, given there was a risk of recurrence if it was indeed FNAIT, and given the potential for prenatal intervention if it was, that it was appropriate to proceed with ruling it out. If we can have the next click, please. So what we did is we went ahead and sent a paired sample of maternal and paternal blood for NAIT screening. We used the Versity Lab, the former blood centers of Wisconsin, for this, and we used their screening cascade. And if you can click again. What we found was the maternal sample did have platelet antigens for both HPA, or just had HPA-1b antigens with anti-HPA-1a antibody. And the paternal typing was indeed heterozygous for this. I'll pause there again for a second.
Some of the material that's pertinent to this, I'll cover later during the talk, but I did think at the time that it was totally brilliant that the MFM consultation considered the possibility of FNAIT, and the number one reason would be the depth of the platelet count.
And then next slide, please. Over some subsequent consultations, we counseled the patient about her findings. We recommended proceeding with further testing given the heterozygous status of the father. And we discussed the possibility of intervention prenatally if indeed the possibility of FNAIT was confirmed. The patient did agree to amniocentesis. Our fetal diagnostic center did a wonderful job expediting this for us, as we were now sort of approaching the point where treatment would be needed. And the amniocentesis did return with a fetal patient who was indeed heterozygous as well. This test came back actually at 19 weeks. Here at Duke, our adult hematologists help us with treatment in these cases, given their greater familiarity with our infusion center. And Dr. Shah from our hematology group was able to get the patient in to start her IVIG infusion sort of right on time at 20 weeks. And next slide, please. The patient has been maintained on IVIG at the 2 gram per kilogram per week dose. She did have several adverse effects from therapy, including headaches, a false positive syphilis screening, and palpitations we've managed conservatively. Her baby has grown normally to date. She was started on prednisone at 32 weeks. She's now 34 weeks today. And we offered her the option of a periumbilical blood sampling for mode of delivery planning. The patient preferred, though, planning for a primary cesarean delivery, and she's been scheduled for such at 37 weeks.
If it's okay, I would just mention a couple of things. Dr. Federspiel and Dr. James in the management of this followed recommendations on dosing that I will try to demonstrate why in the course of showing you some data. Headaches are probably the #1 problem of giving IVIG, and we actually reported them in ITP in a publication back in 1983. Probably the best thing to do for those is steroids and possibly the addition of a little bit of free water. False positive screenings for a number of different antibodies occur because of you're giving all this IgG that's coming from normal donors. So we've also seen it for HTLV1 and other things like that. There are follow-up studies that I'm not going to show you data about suggesting that this type of treatment does not interfere with fetal growth and development, which is good. Back to the amnio, I'll talk later about the fact that cell-free fetal DNA is coming online. So hopefully in the future, it will be possible to use that instead of doing an amniocentesis to identify what the fetal antigen type is, at least for HPA-1a/b and possibly others as well. So thank you for presenting that kind of amazing case.
Dr. Ade-Canedo, will you present the second case?
Absolutely, and thank you for that amazing introduction, Dr. James. Next slide, please. This is a case of a 29-year-old G1 P1001 who presented for preconception counseling for a history of neonatal alloimmune thrombocytopenia with a positive maternal HPA-1a antibodies. Her medical history was non-contributory. As far as her obstetrical history, she underwent an induction of labor at 39 weeks and 2 days for newly diagnosed gestational hypertension. Her pregnancy was also notable for asthma, obesity, and a resolved low-lying placenta. Next slide, please. As for her hospital course, she had a forceps-assisted vaginal delivery for persistent occipital posterior presentation and maternal exhaustion. Immediately after her delivery, there was noted bruising on the neonate, as well as bruising documented during the first bath. The medical team began to suspect a coagulation abnormality after the patient's son experienced prolonged bleeding following circumcision. His platelets at the time nitered at 6,000. Per the patient's report, she was told that she was too anemic to donate platelets. Unfortunately, we were unable to obtain detailed medical records for her son's hospital course. Her son subsequently had a head ultrasound, which was unremarkable for the patient's report. The patient's son was then discharged at 1 week of life with a platelet count of 226,000. Since discharge, her son has not experienced any additional bruising or bleeding issues, and he is healthy and thriving to date. The patient and her partner subsequently underwent workup for alloimmune thrombocytopenia. The patient was negative for HPA-1a antigen, and her partner tested homozygous for the antigen. Next slide, please. The patient and her partner was counseled on the extremely high risk of recurrence and that the goal of obstetrical management would be to prevent intracranial hemorrhage, both in utero and at the time of delivery, as well as any additional associated complications. We discussed our recommendation for antenatal therapy with IVIG 2 grams per kg per week, starting at 20 weeks, in combination with empiric salvage therapy with prednisone, 0.5 milligrams per kg per day PO, starting at 32 weeks gestation to delivery. We also reviewed our recommendation for serial growth ultrasounds in the 3rd trimester and weekly antenatal testing, starting at 32 weeks for antenatal surveillance, establishing care with maternal fetal medicine immediately following conception, co-management with adult hematology for IVIG administration, and banking maternal platelets via pheresis in advance of delivery. Finally, we discussed the general recommendation for delivery no later than 37 weeks via cesarean delivery. I'll now turn it over to Dr. Bussel.
Thank you very much, Dr. Ade-Canedo. And with your permission, I'm going to go into the talk and I'll try to bring up specific issues connected with cases as we go through. I'm having trouble advancing the slide, so if you don't mind, thank you. Next slide. Next slide. Just can you keep going through this one till we get to the bottom? Thanks, that's it, perfect. It's estimated that FNAIT occurs in about 1 in 1,000 live births, so that's about 4,000 cases per year in the US. Typically, like the case that Dr. Ade-Canedo presented, you'll have a mother who largely would be well. She had, I guess, gestational hypertension, but generally would be well. You have a full-term baby who looks fine, and then is exactly as described in her case. You see signs of bleeding, and a blood count reveals a very low platelet count. In Dr. Federspiel's case, it was interesting because the blood count was not done for any signs of bleeding, but as a rule-out sepsis, and that's probably occurs in maybe 20% of cases that are identified. And we've talked about what the standard of care for treatment is. I am not sure why I can't get it to advance, but I can't. So next slide, please. I got interested in FNAIT serendipitously. When I say locking the barn door after the horse had escaped, as a pediatric hematologist, you would see a baby like the ones described by Dr. Federspiel and Dr. Ade-Canedo, and then you would try to quickly run around taking care of business, which involved getting a head ultrasound to make sure there wasn't an intracranial hemorrhage, because that would have adjusted management significantly. And after a while, you realize that no matter how good a job you did on the neonatal management, the hemorrhage had either occurred or not, and you were working on something that was already determined. This meant that I had like a mindset of trying to do something earlier. And then in 1983, there was a couple who had had a severely affected baby with a very low count, a picture of which I'll show you in a minute. And that baby died at 38 weeks on day 1 of life of an intracranial hemorrhage. But the autopsy and the CT showed that the ICH had actually begun 6 weeks earlier. Testing, as in Dr. Ade-Canedo's case, showed that there was HB1A incompatibility with the homozygote father, given that testing for homozygosity then was much more primitive than it is now. The mom was 41, and given that this was 1983, this was her last chance to have a child. She was a neurologist, and the father was a neuroradiologist. She had been precepting in clinic, this is after the death of her child, and saw a journal that had an article that documented that intracranial hemorrhage in FNAIT occurred intraparenchymally instead of the common premature type hemorrhage, which is intraventricular. So she and her husband came to see the neonatologist and asked if their baby could have had FNAIT. Next slide. This is the baby. You can see all the bruises and petechiae. Again, the only abnormality was a platelet count of 3,000. Next slide. And this is another baby's intracranial hemorrhage. And the point I would make here is you can see the whitish part is hemosiderin, and this takes a number of days to develop. So this study, and the same would be true of ultrasounds done at day 1 of life, meant that this hemorrhage occurred well prior to birth, not as a result of head trauma, which is what we used to think. And that's why it's never been possible to show that cesarean section prevents intracranial hemorrhage, although we still do it to be on the safe side. So it's important to get the head study early so it's easier to discriminate antenatal from postnatal. Next slide. So at the time, the standard thing to do would have been to do an elective cesarean section at 37 weeks. But even then, it was pretty clear and generally accepted that the next baby would be at least as severely affected. And therefore, if we waited till then, that baby would likely have had an intracranial hemorrhage already. And we didn't think we could electively deliver at 26 to 28 weeks. So plan A, which we attempted to initiate, was to do what was then current management of severe hemolytic disease of the fetus and newborn. Recurrent serial plasmapheresis, steroids, and azathioprine. The mother, however, had a marked hypotensive reaction to her first and only pheresis and refused azathioprine. We didn't think we could get by with just steroids, and it happened that I was pretty much the first person in the United States to use IVIG for ITP, and I had started that in 1981, so I was pretty familiar with it and managed to arrange on short notice to give IVIG to this mother along with dexamethasone. We decided that we didn't want to give a dose that might undertreat her and then not know what had happened. So we gave 1 gram per kilo per week, which especially back then was a huge dose, and dexamethasone 5 milligrams daily. It worked in the sense that the baby was born electively early with a platelet count of 30,000 and no intracranial hemorrhage. We were able to fly in matched platelets from Milwaukee to give to the baby right after birth. And currently the baby, to the best of my knowledge, as of several years ago, is an associate professor of medieval French literature at Columbia. So this led us and encouraged us to go forward. Next slide. FNAIT's the platelet equivalent of Rh disease. As you saw from the testing and may know anyway, the mom lacks the platelet antigen, usually HPA-1a. The fetus gets it from the father. We believe she's exposed to it by fetal platelets, though that may be debatable, or let's put it another way, has never been clearly shown. Because it's foreign to her, she makes a strong antibody to it. So she makes anti-HPA-1a, which used to also be called PLA1. This antibody crosses the placenta. It increases passage as gestation progresses as the placenta gets larger. It destroys fetal platelets. Recently, with Martha Sola-Vissner, we were able to strongly provide evidence that it inhibits platelet production. And that's probably why the platelet count can be so severely low so early in gestation as it is. And it also probably could react with endothelial cells because, as you'll see later, HPA-1a is on GP3A, which is also on endothelial cells. Next slide. Now, there's two ways that cases get described, so if anybody reads the literature on this, it could be confusing. One is cases like this, and the way cases are generally thought of in the United States at least, where they're clinically identified by bleeding, like the cases that Dr. Federspiel and Ade Kanedu presented, and the disease incidence may be a little lower. We were able to show that, especially in severe cases, the first fetus is typically affected, and the ICH rate is something like 10 to 20%, and most of them occur in utero, as we discussed previously. The birth platelet counts are very low, and I'll show you data on that. But in the study that we did looking at our first 107 maternal fetal pairs, we found that half of them, 53, had fetal platelet counts less than 20,000 by 24 weeks of gestation. And also that in 42% of cases, the fetal blood sampling platelet count in the second fetus prior to treatment was lower than the birth platelet count of the first affected fetus, which is consistent with the idea that subsequent cases get worse. And while, like I said, everybody's believed that, the information on that is hard to find to document. Next slide. Screening cases are milder, more common, and so on. And I'm only mentioning that if you see different numbers, that could be why. Next slide. And the reason to focus on FNAIT, commonest cause of ICH in term newborns, and the commonest cause of severe thrombocytopenia in all neonates. Number 2 in a series from France from fetal blood sampling were CMV and rubella and toxoplasmosis infections. It also, as was indicated in the MFM note, this is going to occur in the next affected pregnancy when the dad is a homozygote, or if he's a heterozygote, it's a 50-50 chance, and that makes it very important because other things typically don't. And we also know now, which was not the way it used to be, that there's data suggesting that random platelets work pretty well in at least 75% of cases, especially if also given with IVIG. Next slide. So it's likely that there are 500 to 1,000 cases of ICH because of HPA-1a alloimmunization every year in the United States and Europe. And this is way more than the combined number from ITP, chemotherapy-induced thrombocytopenia, and inherited thrombocytopenias. Next slide. This is taken from the Blood Center of Wisconsin Versity Lab, and you see, and this has been shown in a number of other previous studies from other centers, that 80% of cases are HPA-1a, and this is even more so when the cases are severe, when the thrombocytopenia is severe. Next slide. We see here some recent work from, this part is not recent, but locking it in is very recent, from Peter Newman's group at the Wisconsin Blood Center, where you can have 2 anti-HPA-1a antibodies, and we don't know yet if it's clinically important to distinguish. One of them, as you see on the left as you look at it, just binds to the leucine-proline polymorphism area. The other one requires that another part of the GP3A molecule swing in and contribute to the antigen. and whether this has any implications clinically is a subject of active investigation. Next slide. We see here a map of the out of Africa, and the point is that PLA1 was the ancestral form, as you see in the bottom, and then PLA2 came to the United States primarily from Europe. You see here going where it was a later polymorphism that developed and only arrived with the European population coming. So in Asia and most of Africa, the incidence of HPA-1A incompatibility is much lower than it is in the US and Europe because the incidence of being PLA2 or HPA-1B is much lower, and there are other antigens involved. Next slide. You see here a picture of, you see here a picture of the antigens also taken from Peter Newman. Next slide. You see where the HPA-1A, PLA1-2 polymorphism occurs, and you see that many of the antigens are on 2B3A. What's important to consider is that the ones on 3A are promiscuous, meaning they're the ones seen on endothelial cells and syncytial trophoblasts, whereas the 2B ones are platelet specific. HPA-9B is a cause of severe alloimmune thrombocytopenia and is difficult because you can't measure antibody to it well. Fortunately, it appears to be very rare. The one case I've seen actually is a woman from Atlanta. Here you see HPA-5, and HPA-5B in multiple populations is the second most frequent cause of FNAIT. Because we believe, and this may not be the reason, because there are 2,000 GP1A2As on the platelet surface and 56,000 GP2B3As, that may be why HPA-1A incompatibility is more severe. And lastly, where you see PEN, which is HPA-4, this incompatibility is the most frequent one in Japan and China. So it's very important to specify ethnicity in talking about patients. Next slide. And like the case that was presented, this sample testing where you look at all the different platelet antigens, in this case, they're all matched up except that the mom does not have HPA-1A and the dad is a heterozygote. Most HPA-1A positive people are homozygotes. So this is not that frequent, but becomes important as we'll get to at the end. Next slide. And here you see the antibodies, and by choosing known control donors and focusing testing on certain glycoproteins, you can be pretty certain that you have, as in this case, an HPA-1A specific antibody. This should all be considered an advertisement that you should only use Versity for testing in this area, because otherwise it's possible that various errors will arise. Next slide. There are many things that can cause confusion. Testing results could show, for example, that the father and mother are incompatible for HPA-3B, but there may not be any antibody identified. Generally, we would just use that as an excuse to screen serially for antibody, but not consider it FNAIT. We talked about 9B. If the mom has an antibody that binds the paternal platelets, but you don't have an antigen incompatibility identified in the panel, you're dependent on the lab to work this up. And what I mean by that is you're dependent on the lab to find out what that antibody is directed to. It could theoretically be an HLA antibody or other types, but it could be an antibody to a very unusual antigen, and the Versity lab is very good at evaluating that. Similarly, you could have a severely thrombocytopenic baby where you don't find any explanation, and then you can't tell if there's a very low frequency platelet antigen incompatibility, and because of that, you can't identify the antibody. And that's a reason why it's really important to use the paternal platelets in the testing. The flip side of that is, as in the case that Dr. Fetterspiel presented, where you have a baby who has a reason to be thrombocytopenic, but also turns out to have FNAIT. And that's a reason to do the testing, as was done in his case, even when you think you know why the baby could be thrombocytopenic. And in a series that we published in 2005 of 111 cases of FNAIT, almost 40 of them had other clinical events happening that you could have construed as causing the problem. You see also on the bottom a number of other issues. I already told you that you shouldn't accept the send to a local lab if you possibly can't, and we'll talk about the other issues with screening. Next slide. A lot of different reasons to have neonatal thrombocytopenia. Typically, in these cases, the platelet count would be more like 50 to 100. Also, the inherited thrombocytopenias are the ones that could look the most like FNAIT. So it's really important to not say, for example, oh, the baby's platelet count was 60, that's fine, we don't have to follow it anymore. Follow it to normal, even if that means asking the pediatrician to do a count a month later to make sure you're not missing an inherited thrombocytopenia. Next slide. In yellow, you see what are the two best parts of a bedside diagnosis algorithm. Neonatal platelet count less than 50 and a good response to random platelets does not exclude FNAIT. That's very important. We originally showed that in that study in 2005, and a year later, a study from Germany with one center in Canada confirmed that. Next slide. We use 50,000 because you'll identify 90% of the FNAIT babies. If you wanted to pick a cutoff for identifying babies that are mostly FNAIT, you'd use less than 20, but you'd miss 50% of the FNAIT babies. And then, of course, you'd wait for a laboratory confirmation. And you saw, as in the case presented by Dr. Fetterspiel, that you get typically a rapid response to treatment and a stabilization of the count relatively early. Next slide. We talked about random platelets. It's rare to need matched platelets. And we talked about the features of this. Next slide. It's important to know the fetus will be affected. So when you have a heterozygote dad, you need to find out the fetal platelet type. And again, cell-free fetal DNA will be the best thing. Next slide. This is the first study we published on it, and I just want to illustrate some things quickly. First, you can see, as we said, that the fetal platelet counts are very low early in gestation often. Second, when there's no treatment given, the fetal platelet count falls from 22 to 28 weeks, and we attribute that to the increased passage of anti-HPA-1A antibodies in this case. Third, when we did fetal blood sampling, which we do not recommend currently, the fetal platelet count could be accurately measured. And finally, when treatment was given, you could see that the platelet count actually went up. And cases 5 and 7 were cases where the previous sibling had an intracranial hemorrhage. Next slide. The point of this slide was to see if low-dose dexamethasone would have an additive effect to IVIG, and it didn't. We used low-dose dexamethasone because higher dose, 3 and 5 milligrams daily, led to substantial oligohydramnios when combined with IVIG. But what I want to point out to you is that we divided these, and the top 2 graphs are for platelet counts less than 20,000 in the fetus. You see that the responses to IVIG alone, a gram per kilo, with or without the dex, are not very impressive. Whereas when the platelet count is higher, the response is much better. Now you notice some of these where the no response and then the count goes way up, like here, for example. Next slide. This is where as salvage, we gave 60 of prednisone, and you see in 5 of the cases, the platelet count increased substantially, even though IVIG with or without dexamethasone had done nothing. Next slide. So we felt that IVIG alone, and we demonstrated that in this study also, was not enough. You see that the platelet count from pre-treatment to the fetal blood sampling 4 to 6 weeks later only went from 8 to 22, and half the babies needed salvage because many did not respond initially. Whereas when we gave IVIG plus 1 milligram per kilogram of prednisone, based on what I just showed you on the previous slide, we had a much better response and very little need for salvage. So this is the basis for what you saw in the 2 patients, that 1 gram per kilo of IVIG is insufficient therapy. Next slide. And this is a study showing that when we treated aggressively, starting at 12 weeks with IVIG 2 grams per kilo and steroids, we were able to avoid recurrent intracranial hemorrhage due to thrombocytopenia in all but 2 cases, and they would be managed differently today. Next slide. And I think the audience probably is aware that fetal blood sampling has complications, and that's why we've eliminated it. Next slide. Or recommended eliminating it, I should say. Certain centers still like it. And relative to the idea of why add additional therapy, about 15% of cases on fetal sampling at 32 weeks in our last study still were thrombocytopenic despite IVIG 1 gram per kilo twice a week, or IVIG in a lower, more tolerable dose of prednisone, 0.5 milligram per kilogram. So we still had some babies with low counts. Next slide. When we added salvage, we call it, so that you're giving, at 32 weeks, you're giving everybody 2 grams per kilo per week of IVIG and 0.5 mg per kg per day of prednisone, we see that 11 of the 13 had a nice increase in their count to well over 50,000, even though there was limited time available for the treatment to take effect. And that's what we currently recommend and what was being used in these 2 patients. Next slide. Next slide. Next slide. And what's important is that if we follow this, we think we can get essentially 100% avoidance of intracranial hemorrhage in cases where there is no past intracranial hemorrhage. But we're certainly going to be over-treating a lot of the patients. And as you saw in the case that Dr. Fetterspiel described, there are issues to the mom of doing this in addition to the time and the expense. Next slide. Now, I want to tell you about some of the new developments, and this is just coming out. It's available online in the American Journal of OBGYN. Next slide. There is screening that is being considered and going to be pursued, which will include fetal HPA typing and DRB3-0101 typing. We'll come back to that. Prophylaxis is being developed, and we can talk about the findings. So if you take 1 million pregnancies, 2% are HPA-1A negative, and that leaves you with 20,000 cases. Next slide. Of that 20,000, we screen for DRB3-0101, and that takes it down to 27% of cases, and that's 5,346. We think it's very rare that the mom will have pre-existing antibody, but we put 1% in just in case. Next slide. This is summary of a Blood Advances article from 2019 that Dr. Schultz and Craw really did, looking at studies of the role of DRB3-0101 in FNAIT secondary to HPA-1A. And you see that the prospective studies, all 64 women who delivered severely thrombocytopenic newborns were DRB3-0101. In the retrospective studies, there were 9 who were not DRB3-0101, but there are many reasons for thrombocytopenia, and it's not clear that they were excluded, nor were other causes of ICH. So we believe this is a very valuable set of testing. Next slide. Then if you do cell-free fetal DNA, about 15% of fetuses will be HPA-1A negative. It obviously depends on paternal zygosity, leaving you with 4,544 of the 1 million who are at risk of developing FNAIT and would benefit from prophylaxis. Next slide. And prophylaxis is being developed. Remains to be seen how this will go. Next slide. Now, I want to talk for 1 minute at the end now about FcRn. FcRn is a very unusual Fc receptor. It only binds IgG in an acidic environment. So either antibodies are brought in via other Fc receptors, or plasma is pinocytosed. It goes into an acidified endosome where it can bind FcRn. The FcRn then traffics it to the cell surface, and then the IgG is released because it's physiologic pH again of 7. So this also is the mechanism by which IgG goes from the mom to the fetus. Next slide. So if you inhibit FcRn, you could block transfer of adverse maternal antibody into the fetus. And this could be anti-D, it could be anti-HPA-1A, it could be anti-Rho, could be anti-thyroid, could be other. In that setting, both maternal and fetal IgG levels will be substantially reduced. There will be a risk for maternal infection and for low postnatal IgG levels predisposing to sepsis. And these risks are being evaluated in an ongoing study of hemolytic disease of the fetus and newborn with an FcRn inhibitor being given. Before this ends, too much like science fiction, I would just mention that there are 4 or 5 companies that have FcRn inhibitors in clinical trial, and data has been published in ITP, myasthenia gravis, and pemphigus vulgaris, among other antibody-mediated disorders, where lowering the IgG antibody level, autoantibody level, would be of use. Ideally, this would completely eliminate the need for maternal prednisone and IVIG, and would simultaneously not only block transfer, but reduce levels of those antibodies in the mother. And as I said, this is actually in clinical trial. So, last slide. In 1980, when we had an FNAIT, back one, please. In 1980, when we had an FNAIT affected mother, we would have said do an early cesarean section. In 2021, you've heard about and seen some of the data about providing stratified therapy to the mom, and FcRn inhibitors are being developed. What I hope, and 2028 is obviously an arbitrary time, that there would be routine screening and prophylaxis in cases of FNAIT would be rare, like RH disease is now very rare. And for the few affected cases, either from other platelet antigens, missed prophylaxis, or large fetal maternal bleed, FcRn inhibitors would be the standard of care, and these would be a sub-Q injection once a week. Thank you for the opportunity to present this work.
That's so amazing. Thank you so very much. If you're ready, I'll launch into some of the questions.
Sure.
The first, thank you for this wonderful talk. With thrombocytopenia occurring often in babies without any obvious cause, FNAIT ends up on the differential even without ICH and without bruises, petechiae, and a platelet count less than 20,000. Since confirmation takes time, these babies are given IVIG. What are your thoughts about this possibly leading to overdiagnosis? Confirmation often is not possible if insurance does not cover antigen antibody testing for the mother and father.
Well, I think insurance should cover it when the baby's very thrombocytopenic, and there's certainly data out there. Nobody wants to have a peer-to-peer for every case, but there's certainly ample data for that. As far as the treatment, the study from Germany, in addition to the work we published, strongly suggests that you can give a random platelet transfusion, and it will probably work most of the time, so that you don't have to know automatically why the baby's thrombocytopenic. Also, if you suspect FNAIT, giving 3 grams, let's say, of IVIG is not exactly a huge expense to the healthcare system, because you have a pretty small baby that you're treating. So I would do that if I thought it would. I mean, I would add the IVIG if I thought it was FNAIT, but I don't see it as that big an issue. And the implications of missing recurrent FNAIT are large, so I don't see issues with doing the typing either.
Before I ask my questions, I want to ask Dr. Fetterspiel or Dr. Ade-Canedo if they have any questions related to the specific cases they presented or any other cases. And if not, having seen this research and our current protocol evolve over time, thank you for staying with it so that we have the story to this point, and it sounds like there's a next chapter. Very early, azathioprine dead-ended. Do you have any thoughts? We use azathioprine liberally in our transplant patients and our patients with autoimmune disease. We think it's a relatively safe medication. Any thoughts about whether that might be effective or not, and has anybody looked at it perhaps in Europe?
If somebody else has looked at azathioprine, I'm unaware of it. I think that's a perfectly good option. I think the use of it, and correct me if I'm wrong, because you probably know more about this than I do, in like renal transplant patients in pregnancy has been remarkably safe. So
Exactly.
I think
And
that's
our lupus patients too.
I think it's a perfectly acceptable thing to consider. I think one of the issues with it, at least as I'm aware of it, is it takes time to work. So that may or may not be an issue, but I think if somebody wanted to do a study of that or evaluate it, it would make sense. Another thing we've thought about, you probably know there's gradually increasing data on the safety of TPO agents in pregnancy, at least in the second and third trimesters especially. So potentially, if you, for example, gave romoplastin, and because it's a peptibody with a FC portion of IgG attached to it, and you would expect it to be transferred across the placenta, that might be a good way to get the baby to make more platelets and bring up the count also. I think fortunately this is a rare enough disease that you can't test everything, but I think azathioprine is a perfectly viable thing to think about.
I had a question.
Go ahead.
I was wondering, with development of even more effective therapies potentially and better screening and our improving knowledge about sort of when these intracranial hemorrhages actually occur, you could be looking at a future in the future where we could offer vaginal delivery sort of in the absence of pubs for these patients.
I think that's a great point, and I think that I think the modal point for the intracranial hemorrhages is probably 32 weeks, but more to the point, we need to know what is happening in the baby without having to resort to fetal blood sampling. And the lack of an accurate biomarker, at least at present, doesn't allow us to know that. So I think if we had a biomarker, that would be great. There's some work with the titer of antibodies, but I think that distinguishes between pretty much unaffected altogether and more severely affected. But I don't think it tells you that fetus A has a platelet count of 10 or 20,000, let's say, and should undergo maybe cesarean section just to be safe, versus fetus B has a platelet count of 40 or 50,000 and is probably fine for vaginal delivery. I think we need the biomarker more. And I understand that was probably why you offered the possibility of a fetal blood sampling at 37 weeks, because that would allow you to not do a cesarean section and would allow you to rescue the baby if there was any complication of the sampling.
I know we're over time, but there are a couple of other questions that I think others will have. One is from Dr. Ade Canedo, and that's at what gestational age would the FcRn inhibitors be administered?
I think that gets, sorry, go ahead.
No, that's it. That's the question.
Oh, I think probably you would mimic IVIG as far as timing, and I think the reason is I believe in the absence of data that the main effect of IVIG actually is on inhibition of FcRn. You inhibit by saturating it. When you're giving a gram per kilo of IVIG, that's about as much IgG as you have in your body anyway. If you give 2 grams per kilo, you get much more. And there's some placental perfusion models which really are looking at FcRn. And if you get IgG levels of the type you get with 2 grams per kilo, you're blocking 90% of transplacental transfer. But you can block essentially 100% with an FcRn inhibitor. So I think it'll be interesting to see whether the study for HDFN can be finished, and hopefully they're going to take it further to FNAIT.
There's a question from Dr. Kulkarni. Is the severity of thrombocytopenia the same in preterm babies as opposed to term babies with FNAIT?
The only way I can answer that, Roshni, is by saying that you saw on the fetal platelet counts how low the fetal platelet counts are even by 24 weeks of gestation, less than 20,000 in half the cases. So I think in general they are as low. Certainly in cases that may be a little less severely infected, they will fall later in the pregnancy. So probably you're right, it's not as severe in the premature infants, but I don't think you can rely on that.
There are a number of other excellent questions, and I apologize that we've run out of time. I hope that what I'm going to ask for our staff, who on the call we have our Director of Education, Kim Roque, and we have our Executive Director, Carrie Funkhauser. I'd like to thank them. Also, for technical support, we've had Kat Hughes. I'd like to ask them if they could perhaps share these questions with Dr. Bussel, and we could post the answers on the Ask the Experts feature on our website, FWGBD.org. Maybe we can get an email out to the participants and let them know what that link is and where the answers to those questions will be. I'd like to thank our fellows, Dr. Fetterspiel and Dr. Ade-Canedo, for doing such a nice job collating and presenting the cases. And Dr. Bussel, thank you not only for this presentation, but for your lifetime of work to eliminate this problem and everything you do to improve the outcome of pregnancy for our mothers and babies. And before we sign off, I'll just say that we may be in touch with you about having a journal club with Dr. Berkowitz when the new article comes out in the American Journal of Obstetrics and Gynecology. I'm sure that would be welcome by FWGBD and our fellows. Thank you.
Dr. James, you've always been a great example of exactly what you described, and I'm sure if we gave your fellows time, they'd be more than happy to tell loads of stories about all the work that you do in this area. So all I can say is I'm honored to be on the same podium with you. Thank you very much.
You're kind. Thank you so much. And we'll sign off, but we will be communicating with the audience so that you have the link to fwgbd.org to get the answers to your questions. And thank you again. Bye-bye.